We've so far talked about different perspectives on nutrition, behavior modification to some degree. We've talked pharmacy and medications. Now let's look at some case studies and dive a little deeper into the complexities of case management and see what we can do here. And boy, are we lucky to have our next presenter with us here today. Most of you folks, I believe, know Dr. Bertheau from Adventist Health. In addition to being a somewhat rabid Seahawks fan, he is one of the most esteemed diabetologists in our region, and he's going to come through and take us through all kinds of interesting stuff today. So please give a warm welcome to Dr. Leonard Bertheau.
So interesting, since you mentioned the Seahawks. I have a medical student who's rotating with me, and she asked if I was a fantasy football fan, and I said, no, actually, I'm a real football fan. I actually have a team that I follow, I bleed for, so I'm definitely a Seahawks fan. So setting the stage, this slide was more or less a recap of what we went over last time, and I was going to try and just kind of briefly review what we had talked about and see how has this impacted you, if at all. I think we kind of talked about it a little bit earlier, and I think there's a lot of new faces here today as well. So I think I'm going to look at it more as just a brief summary of what we went over as opposed to a brief review. So obviously diet, that was kind of the biggest portion of what I talked about last time, and we spent a big portion of today talking about it. That's really where the rubber meets the road. That's where we can have the most impact, and that's where the patient can have the most impact on this disease, is through their diet. So we spent a long time talking about carbohydrates the last time, and we went over it all over again today. And apparently we still haven't learned our lesson because we're still eating high-carb foods. No, I'm kidding. So I guess for those of you that were here in the past, has that helped? Have you been able to have some successes with your patients in educating them about carbohydrates? Uh-huh. So the messages are getting out there to our patients. How much of an impact is it having? It's hard, isn't it? Especially with this patient population, what do they get to eat? Very shoestring budget items that are very high in carbohydrates. Yeah. Oftentimes they'll get plenty of carbs at the beginning of the month, and then at the end of the month, they're hardly eating anything. And it's hard. It's hard with this population. Meals on Wheels. Does any of your patients use Meals on Wheels? If you've ever sat and counted Meals on Wheels, there's a ginormous amount of carbohydrates in some of those meals. I think they're starting to get better. I think they're having diabetic options that I've been hearing has a lot fewer carbs, but I know I sat down with a lady years ago and we went over her carb intake for that one meal, and we easily got over 120 grams of carbs in one meal. I'm thinking, that's not helping. I'm glad you got food, but it's a lot of carbs. Checking blood sugars. Honestly, I'm not sure what I talked about last time, but this is my rule of thumb. I like to see more than just morning blood sugars. Oftentimes, patients will just check first thing in the morning, that's it. I like to see what's going on at other times of the day. This is often what I'll tell patients. If I can get them to check twice a day, I like a morning sugar, and then I like them to rotate that second sugar before lunch one day, before dinner the next, and at bedtime the next, so that I can see throughout the day what their blood sugars are running. And that way, with just two finger sticks, I get a day's worth of blood sugars, on a weekly basis or monthly basis. When I look over their logs, I get to see what they're trending throughout the day. If they refuse to do that, then I'll try and get 2 times, one before breakfast, one before dinner, or one before breakfast and at bedtime. So at least I can see what's happening at other times during the day. Go ahead.
Do you have any good tips for patients who over-test, how to kind of quell their fears of you don't need to test 6 or 7 times a day and this is when it's best to be testing?
That's a very interesting point. I honestly have never really considered the concept of over-test.
Because most Medicaid and Medicare plans only cover a certain number of strips a month, so patients the first couple of weeks will test 6 and 7 times a day, and then by the end of the month, I'm out of strips, and there's not a lot to be done.
That you can do. Yeah, in that scenario, they're going to have to stretch those strips out. I do have patients that test 6 or 7 times a day. They are able to get their strips. So whether they're paying for it out of pocket, or oftentimes I can do prior authorizations and say, yes, these patients do need to test 6 or 7 times a day, and I do get their insurances to pay for it. Quite honestly, it's not a concept that I've considered, that you can over-test. You really can over-test. If you're testing 15 to 16 times a day, that's a bit obsessive. But that's so rare. If they're willing to test that many times a day, I encourage them. That's great. Let's use those blood sugars. So I don't know that I answered your question. Go ahead.
Well, I was just going to say, one thing that I've done, Dr. Bertheau, that I don't know if you've had an experience with this, is I ask the patient what that number means to them. So if they're coming in saying, well, I tested 8 times yesterday, then I'll say, okay, that first value, what did that number tell you? What time was it? What did you eat? So I kind of try to say, like, is the number giving you information? Or is it giving you some sort of comfort? And then from there we can go on, okay, what information are you trying to get from the number? And then that might help kind of say, okay, well really the information we're trying to get from the number is this. And then how can we make your plan so that 15 times a day, if you are testing 15 times a day, what are numbers 7 through 10 even telling you? Anything that your blood sugar changed from 5 minutes ago? That's something that I've done with patients that are over-tested in a situation where the test strips are limited and it's not a time where you can make a case for more test strips because of hypoglycemia or something else. I don't know if other folks have done something similar.
Go ahead, Erin.
I also had a patient that didn't have insurance yet, and she was type 1, and I said, well, I'm going to help you, get hooked up with your insurance and all this stuff. And she said, well, it's not a big deal because I just have this, glucometer that I got from Target for $20, and the strips are really cheap. So either way, it ends up being like probably less than what my copay would be. And I didn't even know that at the time, so I started looking into it, and there are these generic glucometers with generic strips at places like Target and Walmart and even Fred Meyer that I've suggested to people, and I was just wondering what your take is on those. Are they just as effective? Are they?
Yes, they're just as effective. Yeah, and I've got lots of patients that do that. They pay out of pocket and they're able to find much cheaper generic
Like at Walmart,
options.
you can find one for like $10 or $20, and the strips are like $10 or $20.
Exactly, yeah. So that's how they're able to check that many times. More specifically, I think to answer your question, the valuable sugars to me are going to be prior to each meal. If you're going to check after a meal, wait at least 2 hours, because that has no value to me if you're checking within that 2-hour window. If you're taking fast-acting insulin before a meal, I need to wait at least 2 hours to see what that's done. And then a bedtime sugar. So what is that? 1, 2, 3, 4, 5, 6, potentially even 7 sugars. That would be of value. But we don't need all of that. Like I said, you could use 3 times a day and still give me that window throughout a week.
The 2 patients that come to mind in this question, the barrier in my mind is that they have really low health literacy, so helping them understand the value of those blood sugars when they take them. My one patient, every time he sees a high, he wants to dose his short-acting insulin, which obviously is dangerous, and so my kind of response to him is to get him to test fewer times in the day to mitigate the risk of him dosing too much insulin in a day. So it's almost like a harm reduction standpoint that I'm trying to get them to test less, because when they see any kind of a high, they want to do something.
That's when they blast and then fall low. That's a great point. So maybe for this particular patient, check every time before you eat, because it is safe to give extra insulin before you eat. But otherwise, yeah, you're playing a more dangerous game. Oral medications. So briefly, we went over Metformin. Hopefully everybody's real comfortable with Metformin. Lots of patients are on it. Although, I think there's been a recent update. Do you guys remember from our first presentation what I had asked for you guys to help the providers keep in mind, and that's the GFR? Do you remember that at all? Or? Excellent. So what GFR level should we avoid Metformin in? Do you know? 30, excellent. So if you're under 30, a GFR of 30, we shouldn't be using Metformin. And that is something that providers would greatly appreciate your help, because we can't catch them all. What about between 30 and 45? perfect. Don't start a patient on metformin if they weren't on it already. However, if they are on a current dose, they can stay on that dose if they're stable. And then above 45, it's free. I'm impressed. Sulfonylureas, glipizide, glimepiride, glyburide. Was that helpful to learn what it does and how to utilize that in patients? Again, it goes down to the pancreas, in my mind, and squeezes insulin out of the pancreas. So they really need to be taking it before they eat, not after they eat. Has anybody utilized that morsel of information when they talk to their patients? Yes, no, maybe so. Now would be a good time. Encourage them to take it before they eat. And also, if they take a dose in the morning, they need to eat during the day, because these medicines will be squeezing insulin out throughout the day. And then Actos. Anybody using Actos? Or any of their patients using Actos anymore? We got a couple. It is a generic option, so it might be getting used more and more as we move forward. Insulin, we're going to spend a long time talking about insulin today. And then the GLP-1 agonists, this is the Bydureon once weekly, which we talked about earlier. The DPP-4 inhibitors, I would like to add for the DPP-4, actually not the DPP-4, sorry. The DPP-4 inhibitors are like Januvia. They've been around a long time, very safe, still expensive for now. Hopefully they'll be coming generic soon. The SGLT2 inhibitors, this is the one I wanted to add. Jardiance recently has some new information that there is cardioprotection involved with Jardiance, as well as improved kidney function. With these class of medicines, it was thought, since it's having its impact on the kidneys, we had to be very careful with the kidneys. Jardiance has actually been shown to improve kidney function. Say it again. Both heart and kidney. Okay, so now the fun part, right? Now the different types of diabetes, and there's lots more than just type 1 and type 2. And then we'll go over cases. The cases, to me, is the funnest part of this presentation. So hopefully everybody understands the difference between type 1 and type 2. But I'm going to ask you specifically, how would you explain what type 1 diabetes is? Not making insulin is correct, but why? That's the key. It's an autoimmune disorder, meaning the immune system, for one reason or another, recognizes the pancreas as a foreign entity, and it attacks and destroys the pancreas. That's type 1. They have to be on insulin. Yeah, that's type 1. Type 2, what about type 2? We see lots of type 2. What exactly is type 2? That is correct. It starts with insulin resistance. Typically, there's a hereditary predisposition. You have it in your family, but also you're carrying extra weight that leads to insulin resistance, and eventually you need to be treated. You get type 2 diabetes because your pancreas can't overproduce enough insulin, and then we can use things like orals. Oftentimes, we do have to end up on insulin for these patients as well. Doesn't mean that they switch from type 2 to type 1. They're just now a type 2 who needs insulin.
So is that pretty much always the course, is that you have insulin resistance and then your pancreas is overproducing insulin and it gets tired and stops working so well? Is that pretty much always the course?
When I use the word always, I really have to stop and think before I say it.
I said pretty much always.
Pretty much always. I would say, yeah, I think that's a safe way to think of type 2. It is a dynamic insulin resistance, and you're not able to overproduce. Obviously, if you get rid of some of that resistance by weight loss, that's why weight loss is so effective, now all of a sudden we're not asking as much from the pancreas, and we can get a lot more accomplished with what function is there. That help? What about LADA, or latent autoimmune diabetes of adulthood? We can also use the term type 1.5. Has anybody heard of that one? Wow, people have heard. Tell me, what is it? You've answered a lot. I'm going to give other people a chance. I saw some nods right in this general vicinity. You've heard of it. Go ahead.
Maybe post-Whipple or something like that?
Oh, actually, we will talk about that one in just a second. But that's not what this is. I know you know the answer.
The only reason why, though, is because I want to talk about when I was following you for a day, and I was there. while you diagnose somebody with this, and I was just going to say the scenario of a patient, she
Perfect.
was somebody of a normal body weight.
Mm-hmm.
She had actually lost weight over, about a year or two after she found out she was type 2 diabetic, but it didn't improve her diabetes. She was on long-acting only. She was on Lantus and had out-of-control A1C. And you so brilliantly said, you know what? I think you're type 1.5.
Right, that's exactly. Did everybody hear that? She gave a great presentation of a real latent autoimmune diabetes of adulthood patient that I diagnosed. She got to see with me. And it was a perfect example. Did everybody hear that? Yep, okay, good. So yes, so basically, in my mind, latent autoimmune diabetes of adulthood is exactly that. It is autoimmune disorder. It is type 1 that happens much later in life. In my mind, when you're a kid and you get this disease, your immune system is very strong. And it attacks and destroys your pancreas almost perfectly efficiently. Has anybody heard of the honeymoon phase? What the honeymoon phase is?
Yeah, it's after a child they start on insulin, and then they start creating their own insulin again, and it's really horrifying because they have lows then, and you have to cut the insulin way down.
That is correct. So a honeymoon phase is after you start a patient on insulin, whatever's left in their pancreas comes back and starts producing its own insulin as well. You can absolutely see it in kids, but you can also see it in adults. If you get the diagnosis of type 1 later in life, they can get a honeymoon phase. Typically with kids, if they do get a honeymoon phase, it's for a short duration. There's not much of the pancreas left, and it won't stay around forever. Their immune system will attack and destroy the rest of it. As we get this diagnosis later on in life, that honeymoon phase can be very robust and very strong. I've actually made the diagnosis of a type 1, a LADA, at the age of 71, and I expect her honeymoon phase to last the rest of her life. So they present differently than a true type 1 when they're kids or when they're younger and they get this disease. Go ahead.
Question, kind of like the idea of testosterone, like once we start getting it, the body stops kind of producing it, or a lot less, my understanding. Is insulin kind of like that, where you're...
I would say no. So I don't want to steal thunder from a future presentation, so can I come back and answer that? Okay. So does everybody understand latent autoimmune diabetes of adulthood? It is type 1, but it presents and manifests much differently later in life.
I guess I don't understand how you tell that that's what's happening for the patient.
Great question.
And can my providers who are not endocrinologists but primary care providers figure that out?
Send them to me.
For my patients who can't get to specialists.
I know you know the answer.
I just have a great case for that.
You do?
Yeah.
So do I.
It's a really quick one.
Go for it.
Okay, so in primary care...
Actually, if you would stand and face the audience so they can hear you.
So in primary care, we just had a patient who'd been hospitalized something like 9 times for ketoacidosis over the last 10 years. And she thought she was a type 2. And so she came to us brand new, out of the hospital again. I asked the provider just to check for the autoantibodies, and she did, and she found out she was type 1. So,
Perfect.
and we got to get her into endocrinology. So there we go.
It's coming. It's coming. There's cases. This was a primer to kind of set the stage, and then I was hopefully going to show examples, but you guys have great examples. What about double diabetes? What the heck is that?
Somebody with type 1 that has
Insulin resistance.
Perfect. Gosh, I'm getting chills. Type 1 diabetes with insulin resistance. It's a larger type 1 diabetic who, if they hadn't gotten type 1, most likely they would have gotten type 2 later in life. Usually there's a genetic predisposition. They have a family member who has type 2. You're dealing with both diseases, really, and those are hard patients to address. And then, now coming back to yours, type 1 from secondary causes. So the Whipple, side effect from the Whipple is you're going to have lots of damage to the pancreas. In fact, as I recall, it's been a while, Whipple, is it all gone or just mostly gone? The tail part. So, and absolutely we have patients like that are type 1 secondary from the surgery. What's another great example of type 1 secondary from? Pancreatitis. I would say chronic pancreatitis, yes. And that's because of alcohol. There it is. Chronic alcohol abuse. Just like you pickle your liver, you can totally damage your pancreas and end up getting type 1 secondary from alcohol abuse, chronic alcohol abuse. Isn't this fun?
The diagnosis codes for each of these different.
Whew. LEDA. Oh man. Yes. Well, in Epic, in my Epic, I have an option: latent autoimmune diabetes of adulthood treated as a type 1, or latent autoimmune diabetes of adulthood treated as type 2. I have those two options. Are they different ICD-10s? I don't know. Double diabetes, I would say no. I'd say they're type 1, but just in your mind, you know they also have insulin resistance, so you can make mention of it and treat them as such. And type 1 secondary, I also know that I can choose type 1 secondary, and I think they do have their own ICD-10. How's that? Okay. So when should we be thinking about insulin? You guys are already thinking about insulin, and probably you're thinking about insulin in these scenarios. But if not, these would be the scenarios. If their A1C is greater than 9% and they're not controlled by orals, and you've given them 3 to 6 months to help them get their blood sugars down, if they're still staying at that level, probably their pancreas is not functioning well, and they should be on insulin. What about a newly diagnosed diabetic with A1C greater than 10%? It's kind of obvious because it's labeled when to start insulin. But think of a case when you get a brand new type 2 diabetic, and this, by the way, is my favorite case. They come in with an A1C of 14 on nothing. What would you start them on? Just Lantus? Okay, I hear Lantus and Metformin. I would say you're missing one big piece. And now I can answer your question. So, again, my favorite patient, they come to me, brand new, they're not on anything. You had your hand up. Were you going to take a guess?
Well, I've also seen some of my patients where the Lantus is skipped and they're started on an NPH.
Okay.
So I wasn't sure,
I'm not
when
either.
that's appropriate.
Yeah,
I'm
NPH.
working with a patient right now who her only insulin was an NPH,
Mhm.
and he's being NPH. And then we just started her on a mealtime as well.
Excellent.
But she was never on a.
That was the key in my mind, is the mealtime. All right, so my favorite patient, I'm getting looks, this is great. My favorite patient, a brand new onset type 2 diabetic with an A1C of 14. They're coming to me on nothing, and I say, guess what? You need insulin. You need insulin, long-acting insulin, and you need short-acting insulin. You need short-acting insulin prior to each meal, and you need long-acting insulin. And the look on their face is like, what? I'm just brand new diagnosed, and now you're telling me I need shots? Not only do I need shots every time I eat and at bedtime, and I say yes, and this is why. When you're first diagnosed with an A1C greater than 10%, you're in what's called a glucose toxic state. The blood sugars are so high for so long that the pancreas doesn't work. And it's not that the pancreas is dead, it's that they're, for lack of a better term, frustrated. Their job is to produce insulin. When they produce insulin, nothing's happening. The sugars aren't coming down, so they say, you know what, I quit. I use the example for patients that your pancreas is a factory and your beta cells are the little factory workers. And if you can imagine these factory workers working 24/7, always trying to process orders, and their demands are never met, they just keep going. They say, I quit, I walk off the job. Doesn't mean they're dead, they just stopped working. And what I've seen is when I put them on basal bolus insulin therapy or long-acting shots with short-acting shots prior to each meal, usually it's about 6 weeks-ish, I can get them off of their shots. The pancreas comes back, the beta cells come back online, and they're fully functioning again. And I know from 8 years.
Are they then on an oral?
Yeah, and they're on oral medicine. And no insulin, that's correct. I call it rescue therapy. It's the most fun I can have in doing what I do, because I know 8 years down the road, I have type 2 diabetics that I did this with, and they're on metformin, and their A1Cs are down in the 6s. Isn't that cool? And I get paid to do it. It's cool. That's a really good point. So part of the side benefit, I would say, is when you hit them real hard at the beginning like that, it kind of takes up the level of intensity for them, and they're like, oh, this is serious stuff. And if I don't make a life change now, this could be in my future. And so I do think that plays a part of it. It really helps to motivate them to do the right things so that eventually they won't end up on long and short acting.
So say if a provider did start them on the Lantus and short acting, but then they just kind of continue to monitor, see that, you know, their health modifiers are being met, their hemoglobin A1C is being done, but they don't change the insulin.
So if their pancreas comes back, they'll have low blood sugars. So the patients will start complaining, hey, I'm getting 50s and 60s all the time. What do I do? Yeah. Mm-hmm. Only it's more than just a honeymoon phase. The pancreas is back. In my mind, a honeymoon phase is a portion of your pancreas is back. This is full-fledged.
So consistently low blood sugar.
Yep. They won't need insulin. She had her hand up first, sorry.
Do you need to worry about lowering the blood sugars too quickly? Not that they necessarily go too low, but...
Wow, that's a great question. Yes. So
what are you trying to do there?
Yeah, so I will have, and my med student sees me do this all the time, I'll have patients that come in with really high blood sugars. They're used to 300s and 400s. I could take a really good guess and get them precisely on how much I think they might need. And that'll get them from 400s down to 100. And that won't be a fun experience. So I am cautious when I do this. I usually underguess, not overguess. I know I'm not giving as much insulin on purpose because from 400, 3 and 200 is going to be better, and that experience will be a lot more gradual, a lot easier for them. And then I start titrating up on the doses and gradually working down.
So like over those 6 weeks, you're slowly titrating?
I would say, yeah, that's a good question. I would say the titration, happens usually in about 2 or 3 weeks.
And where are you trying, in a perfect world, to get that person in that 6 weeks down from the 10 A1C? I mean, is their A1C going to change that much?
I see drastic drops, yes. I'll see, obviously it depends on when that A1C is and when you're checking the next time, but if I can get them on basal bolus insulin therapy and you start the clock at that moment and then recheck 3 months later, yes, I see A1Cs dropping from 14 to 6 all the time. I get really jazzed too. I bounce around the office, it's fun. So what kind of insulins? We've talked about this already. Basal insulin. How much do you start? What time of day? When to test? So let's talk about that. So you'll see that hopefully there's lots of answers in your handouts. Try not to look at the answers before you think about this and come up with guesses. So when you start with basal insulin, Lantus, how much should you start? 10 units. I hear that all the time. 10 units of Lantus. 10 units of Lantus might be way too much for a really thin type 1 diabetic who's very insulin sensitive. 10 units won't be even close to your very large type 2 diabetics. So it's a common dose that I hear all the time. Do I go into calculation of insulin on this presentation? So rule of thumb for type 1s, total daily dose is 0.3 units per kilogram, and you'll want to use half of that as your basal insulin. And I always underguess. So if that's, 8.7, I would go down to 8. I would round down in that scenario. Does that make sense? Type 2s is going to be closer to 0.5 to even 1 or plus units per kilogram. Start at 0.5 units per kilogram. And again, half of that is going to be your basal insulin, so divide that by 2. If you do that calculation for a big type 2 diabetic, oftentimes you'll be much higher than 10 units, and it's safe to start them higher than 10 units. And also gives you an idea of how much they're going to need so that you can feel comfortable titrating up on them.
Can you say the type 2 population?
Yeah, it's 0.5. I would start insulin naive, 0.5 units per kilogram. And again, it's half of that. So 0.5 units per kilogram is the total daily dose. Half of your total daily dose should be basal, and the other half should be fast-acting throughout the day.
What if the type 2 is only on basal?
I would still start with that. you're assuming that they've started the threshold of their disease state, that they just need the basal. They're okay during the day, so they just need the basal. I would still start with that as your dose, and if they end up needing more, then you should start thinking, well, maybe I need to add the mealtime insulin. That make sense? When should they test for basal insulin? We're talking about, oh, I skipped a step. What time should they take their basal insulin? That's a great answer. When they remember. If you can get them to take it consistently one time every day, get them to take it consistently one time every day. Ideally, if we could say, well, I'll remember any time, just tell me when. Ideally, when's the best time? Bedtime. I heard bedtime. Bedtime was what I was looking for. Now, bedtime, there's a caveat to that. Patients will hear bedtime and think, okay, whenever I go to sleep, that's when I'm going to take it. And they might go to sleep one day at 8, and they might go to sleep one day at 2. So it's more important that they take it that same time every day. So ideally, it's their bedtime. But if they fluctuate their bedtime, get them to take it one time that they'll make sure they go to bed and get their insulin in every day, and then just take it that same time every day. We like them to take it that same hour every day. When should they test to see how effective and efficient the basal insulin is? Right, fasting sugars, that's it exactly. So I have them check their pre-breakfast or when they wake up sugar, and that tells me if their basal insulin is working. What about bolus insulin? When should we add bolus insulin? Do you guys know what I mean by bolus? Before you eat, yeah, mealtime insulin. Okay, that's a great answer. You could start one time a day with your largest meal. I guess my question was more, when do you think about adding a mealtime insulin? And if you get them to check this is why it's so valuable to me to get at least a second sugar throughout the day. If you see that they're waking up with great sugars, but then during the day they go high, obviously they need insulin for the food that they're eating. It's their food that's causing the sugars to go up. And their pancreas now is at a level where they can't handle the carbs in their day. So that's when you should think of it. If you're seeing their blood sugars do this throughout the day, they need insulin before meals. And then when do you test for mealtime insulin? Before meals. Before meals. Keep in mind that their blood sugar before breakfast lets us know what the Lantus did. Their blood sugar before lunch lets us know what the pre-breakfast insulin did. Does that make sense? Yeah, it's pretty obvious, isn't it? Their blood sugar before dinner lets us know what the lunch did, and their blood sugar at bedtime lets us know what dinner did. So keep it in that terms. And I already mentioned this, but your basal bolus insulin therapy should be about 50-50 split. So 50% of your total daily dose should be basal insulin. The other 50% should be your total fast-acting insulin throughout the day.
So that, I was just wanting to make sure we covered dosing for bolus, so that's covering, it's just whatever's left over from.
Great question. So if you're trying to calculate how much they need total throughout the day, their bolus insulin, I've taught you how to figure out the basal insulin, and then the other 50% of that.
You just separate depending on how many mealtime insulins.
Yes, so you could divide it by 3 to get 3 different shots if they're eating 3 times a day, or you can do the carb ratio. Now, for those of you that want this information, it's 360 divided by total daily dose. You'll see in the literature that it's 500 divided by total daily dose, but that's usually not enough. I found that it's 360 divided by total daily dose, and that's going to be their carb ratio. So they divide by that number to get how many units of insulin to take every time they eat or drink any carbs. And that way they're covered, whether they're eating once a day, twice a day, 3 times a day, or if they're eating snacks, or if they're drinking carbs. Did I lose some of you? Sorry. So that's how you can come up with the carb ratio. The other key thing to keep in mind is we've calculated the basal insulin. You can use that same amount throughout the day, divided into 3 meals. You can also kind of adjust as you go. So if they have a bigger meal, Maybe you could subtract a few units from one meal and add it to the next meal if they have a bigger dinner and a light lunch. Does that make sense? (70-30). What are some of the benefits of 70-30? It's simple. You don't have to worry about all this carb ratio business and how many units and what time of meal. 70-30, you take one dose before breakfast, you take one dose before dinner, and that's it. So it's fewer shots, it's more simple. There's a great way to calculate the dose of 70-30. Have I taught any of you this yet? You take the first two digits of their weight in pounds, and that's a safe, good place to start for their dose before breakfast and dinner. So if they're 210 pounds, it's 21 units before breakfast and dinner. So simple, right? Easy, convenient. There's always drawbacks. The drawback is now they have to be very consistent with their mealtime patterns, with their meal times, with the carbs that they eat. There is insulin kicking in at lunch, so if they skip lunch, guess what? They're going to have a low blood sugar. You can't skip lunch. I say this over and over and over to my patients. If you're going to do 70-30, don't ever skip lunch. And guess what they do? They skip lunch. The common scenario is, oh, I did have one low blood sugar. And I'll say, were you out shopping and you skipped lunch that day? They're like, yeah, how'd you know?
Would you recommend a lighter lunch though, because it's not going to be having that?
At least something, yes. Something will help prevent them from crashing. So I say, if you're going to go shopping, take something with you so that you'll have something during that time when that insulin's kicking in. So basal and prandial coverage all in one shot. Less injections per day, less confusion. A vial of 70-30 insulin is the most cost-efficient way to do this. 70-30, either Humulin or Novolin. The cons are you're stuck with that 70-30 percentage. It's not 50-50 like it's supposed to be, 50% basal and 50% fast-acting. What's interesting is if you remember, there was a split mixed insulin that was 50-50. That made a lot of sense to take 50-50 before breakfast, lunch, and dinner. In reality, it doesn't work very well, and I don't know the reason why. So I either put them on 70-30 if they're going to do split mixed, or I separate those two, give them basal insulin and fast acting separately. It's less flexible. So these patients can't just eat whenever they want. They really have to be set on a fixed pattern. They can't skip meals. With the other system, separate shots, they are able to skip meals because you're not going to take your fast acting insulin. If you eat an extra snack or a meal, you just take another shot. And then it requires patients to be consistent with time and carbs. I think I said that already. Low blood sugars. We mentioned this before. I want to reiterate because it really is obviously important. That's one thing that my med students hear over and over is I'm constantly harping at my patients, avoid lows, avoid lows, avoid lows. And they're like, lows? Lows aren't that big a deal. It's the highs I want to avoid. Well, you also want to avoid lows. How low is too low? For most patients, it's under 70. If you're a gestational diabetic, it's 60. Why worry? It can lead to loss of brain cells, it can lead to coma, and it can lead to death. The more exposed to the low blood sugars you are, the less you are able to sense those low blood sugars.
Can you say that one more time?
The more exposed to the low blood sugars that you are, the less you're able to sense the low blood sugars.
Like feel the symptoms.
Exactly, right. So the symptoms you get from low blood sugars, you get shaky, break out in a cold sweat. If you're used to running 60 all the time, you won't feel when you're 60.
Why is it okay for the difference in the gestational diabetes? Why is the 60 acceptable or?
So, yeah, so it's a good question. So if you were to wake up and check your fasting sugar, or if you all were, it's not uncommon for us to wake up in the 60s. It's not an abnormal blood sugar for most of us. So for gestationals, we're a lot more aggressive. They are essentially, outside of the pregnancy, normal, right? It's the pregnancy that's pushed them into this new category. So we can be more aggressive with them. when you're dealing with diabetics that are on insulin, now all of a sudden I'm a lot more worried about low blood sugars. And so I want to make sure they have a nice comfort safety zone. And so 70, especially if they're on insulin or insulin secreting medicines, 70 really should be their rule of thumb. Does that answer your question? I woke up in the middle of the night once, and I was wearing one of these systems just like my diabetes educator wore, and it was a continuous glucose sensor, and it was bleeping at me saying, "You're 68, you're 68, you're 68." And I'm like, so? Turned the thing off and went right back to sleep. So symptoms, we just talked about this. Headache, confusion, personality change, blurry vision. It's interesting when we're asking our patients, what do you feel when you have a low blood sugar? Almost everybody says that they feel shaky. That's one that's really common. But then there's always a second one that's different for every patient. I don't know, I just feel fuzzy. I don't know, I feel angry. I don't know, I can't concentrate. It's different for different patients. Hungry, nausea, gas or upset stomach, sweating, anxiety, dizzy, shaky, that's the common one, and rapid heartbeat. A lot of these symptoms overlap with high blood sugars, and I had a patient who thought he was he thought he was low, so he drank juice. And then he felt 10 times worse. Finally decided to check his sugar, and guess what? He wasn't low, he was high. Sent himself into DKA. So he learned his lesson the hard way. Check your sugar before you treat. So, again, when you're exposed, and I have lots of type 1s who have been type 1 for a long time, and they are more comfortable with lows than they should be, and it's something I keep trying to educate them. And they've gotten used to these low blood sugars. You lose these sensations. You lose the shakiness. You feel just fine when your blood sugar is 50, which is not a good thing. They really need to key in onto whatever they can feel. Oftentimes for these patients, it's a little bit of tingling in the nose, lips, or tongue. That's the last one to go. And if that's gone, then we're really in danger. So educate them to pay close attention to those symptoms because it's not as obvious. Treating a low blood sugar, the rule of 15s, you give 15 grams of carbs and then wait 15 minutes. So 4 ounces of orange juice, 4 glucose tabs, 5 lifesavers, half can of regular soda, nothing with fat or protein, as this will delay the absorption of the carbs. I got a test wrong in med school that the question choices were, should you treat a low blood sugar? And the right answer was a Snickers bar. And I couldn't bring myself to circle that answer. I'm like, no, you're wrong. And I even contested it afterwards, and he's like, well, everybody else chose Snickers bar, so sorry. Like, it delays the absorption of the carbs, come on. If the patient is not awake, they should get a glucagon shot. So this is something that they should have on hand, and family members need to learn how to give it. So if they pass out, don't put anything in their mouth. They could aspirate, but you could give them a shot of glucagon and literally save their life.
But Dr.
Yeah.
One of the things to remember is that once they come to, that they need to be.
That's a good point. When they wake up, feed them. Once you get the blood sugar, maybe I get to this. Yeah, I do. I get to it. So recheck in 15 minutes, make sure that it's up over 70. If it's not, repeat the simple sugars. Just give them simple sugars. Once they're up above 70, then you can chase it with some protein. Give them something with peanut butter. I like peanut butter. It keeps their blood sugars stable for a longer period of time.
So if they are on insulin, should they have prescribed a glucagon?
That's a great question. Ideally, the answer is yes. If they're on insulin, they really should be. They should have a pen of glucagon available at all times. 90%, 99% of the time, they're never going to use it. But that 1% of the time, I want it there. In particular, if they're having lots of frequent lows, then they really should have it. So now to answer your question, is that paid for?
Yeah, I think, it's paid for.
We're good there.
What if they wouldn't want?
Yeah, don't give yourself glucagon. You'll be passed out. You can't do that. So unfortunately, there are no good answers for living alone. Was that you? I was trying to make eye contact there. Normal blood sugars can cause symptoms. Oh, right. So just like we were talking about before, if a patient is used to being 400 and 500, 120 is not going to feel good to them. It's not a low blood sugar, but it doesn't feel right to them. So we need to get them through the hurdle of being able to feel normal at 120. I actually had a call after hours. A patient called me and said, my blood sugar is 120. What do I do? I'm like, really? 120?
Why is that though? Why do they feel like they're low?
Because basically the body's gotten used to high blood sugars as their normal. And so when they come down to the normal range, quote unquote normal range, it's low to them. In particular, a drop feels awkward. So the other thing is, if you're used to having normal blood sugars, but you go sky high and then you drop quickly, even though you're dropping back into the normal range, that drop can feel not normal. So the take-home point is even normal blood sugars aren't necessarily normal to the patient. Hopefully help them get used to it. But also it could be dropping, so pay close attention to those symptoms and pay close attention to your sugars too. So even if you see a 120, you're not out of the woods just yet. You could be dropping further down, so just keep an eye on your sugars.
What did you tell the patient? Like 500. He's just like talking, he's like normal, he's just like, I'm like, are you okay?
Yeah, the human body has amazing ability to adapt. What's interesting though is I'll tell those patients that feel normal up here, when I get you on insulin, you're going to feel so much better. You don't realize how bad this feels. And inevitably, when they come back to me, they're like, you were right. I feel so much better. I didn't realize. Say it again. Mm-hmm.
So if I'm triaging and that patient calls and says they have a 120, they feel crappy, what do I tell them?
Great question. So the context of when you're triaging, if you know that their A1C is actually not too bad and 120 is not an unusual sugar for them, I would say keep a close eye on your sugars, and if you start dropping further, please treat. If they're up here and they're used to feeling normal, my encouragement is help them get used to feeling normal down here again, because the worst thing that they can do is say, okay, and I hear this, 120 is too low for me, so I'm going to treat it and get back up to the 400s. That you won't get past that unless you can help them feel normal down there.
But your body will adjust.
Yep.
Any idea like how long that takes to tell a patient?
That's a really good question. I don't know that I have come up with that answer. I would say weeks.